No, that's not true. Actually, uh, you know, uh, when we do a clinical trial for neuroendocrine tumors, actually, even the trial, if you're familiar with it, NETTER-1, where lutetium dotatate was approved by the FDA, they started at 18, and I think their oldest patient was maybe 78. Well, we run clinical trials here at the University of Iowa in neuroendocrine tumors, and we have worked with the FDA, so our trials say from 6 months to 90 years. And we really, in every trial we include children. In children, if you have a bellyache, we say, are you constipated? Do you have diarrhea? I can treat both of those and you can go home. And actually, this isn't maybe so different from adults, because often adults with neuroendocrine tumors are having symptoms anywhere from 8 to 9 years before they're diagnosed. Well, with children, hopefully we're not that long. I had a 6-year-old, the youngest person that I've treated with peptide receptor radiotherapy, and that child had been having gastroenterology problems from the time she was 3. And I know many of my patients who come in at 10 or 11 years old or even 15 years old have had symptoms related to this disease, which has been undiagnosed for 4 or 5 years. So from that standpoint, it's a little bit short in time in children, but not that much. I think the other differences in children are, number one, children tolerate a lot more medication, tolerated better than adults, and they tolerate surgery better. I work with our neuroendocrine tumor surgeon here, and they are often surprised at how much surgery a child can withstand. Now, I don't advocate every child having all kinds of surgery, but I think the important point is that in children with neuroendocrine tumors, we try to get, especially if we're going to treat them with peptide receptor radiotherapy, we try to get all of the tumor out that we can using surgery, because the less tumor that you have left when you start having the treatment, the more effective that treatment can be. So that's the second difference. I think the emotional impact that this disease has on children and therefore on their families is also not that you don't have it when you're an adult, but dealing with a child who has cancer is, we're understanding now that traumatic events during childhood can have an effect on your whole life, and certainly cancer does. So we are very tuned in to having child life specialists on our team all of the time. And that's not just for, preteens, but that's the teenagers and the young adults as well. Well, that's one very good example of when a neuroendocrine tumor is incidentally found, but that's probably one of the very few times that it is found incidentally. The majority of them are kids who have a bellyache that just can't be, cured, and they see a gastroenterologist, and maybe they're put on antacids, and the antacids don't make any difference. That's one of the big things that I have heard many teenagers say. They gave me antacids and they didn't help. That's a big clue that there might be something else going on. unfortunately, that's one thing that's the same in adults and children. We call this a slow-growing disease, but if it has 3 or 4 years to work before we make the diagnosis, it's not unusual that we have, especially lymph nodes outside in the area of the tumor. And then you all know, as well as I do, that neuroendocrine tumors like to go to the liver, and liver metastasis is very common in children when they're first diagnosed. And I think the third, so bone, lymph nodes first, liver second, and bone third. Well, full body CT, actually full body MRI is coming. And we're probably going to be using that more so. The University of Iowa does not have a full body PET scanner, or full body MRI scanner, excuse me. So the University of Iowa does not have a whole body PET scanner yet, but they are coming. And we probably will have one in the next, I would say, 5 years. Whole body CT to look for a neuroendocrine tumor, no, I would not recommend that. In terms of saying a CT that is a diagnostic CT. Now, I would recommend a PET scan that uses gallium dotatate or dotatate. And with that PET scan, we always do a very low dose CAT scan as well. And they're done on the same machine so that they're perfectly matched anatomically. And then we could be able to pinpoint from the PET scan, do we need to do a scan of a CT of the abdomen, which if we were going to recommend surgery, our surgeons here prefer a CT scan of the abdomen to an MRI of the abdomen. Now, if we were going to look at how much liver metastasis was there, again, we could see that on the PET scan first, and then decide to do, in that case, probably an MRI of specifically looking at the liver. And similarly, if we thought there was a tumor in the pancreas, and this is a case, especially in the pancreas, where you need a very seasoned, expert nuclear medicine person to be reading that scan, because the pancreas has some normal uptake of somatostatin, because a lot of the, as you know, the insulin producing cells are in the pancreas, and they have a lot of somatostatin receptors on them. So the part of the pancreas that has the most islet cells producing insulin already lights up. And so you need a specialist who knows when it's normal light up in the pancreas and when it's not normal. So to summarize your question, we do not recommend either whole body CT or whole body MRI as yet until after we've had a gallium dotatate or dotatate scan.